हाँ जी मिसेस शर्मा, शुरू करें।
हेलो हाय हेलो हेलो हाय। सारा दिन फोन पे रहती है ये कमला। गिरा 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 मेरा गमला।
मैंने बोला था ना।
की कहानी आज बरसे का पानी। पिंकी के पापा प्लीज प्लीज टेक द छाता।
प्लीज टेक द छाता भाई साहब, प्लीज टेक द छाता।
मैंने बोला था ना।
लाल पीला हरा नीला साथ में धुलाएगी। व्हाइट कपड़ों पे क्या रेनबो बनाएगी।
मैंने बोला था ना।
पिंकी बेटा लेसेस, डोंट मेक दोस फेसेस। याद आएगी माँ जब गिरोगी।
मैंने बोला था ना।
बिजली की है तार, भैया बनो नहीं स्टार। हाँ यस नो नहीं।
मैंने बोला था ना।
सबको दिया ज्ञान पर खुद का नो ध्यान। हुआ फीवर थकान, अरे अब तो जाओ मान।
मम्मा एनर्जाल।
पी लो। वेक्टरबॉर्न डिजीजेस जैसे डेंगू, मलेरिया, चिकनगुनिया और टाइफाइड से हाई फीवर होता है। इस दौरान कम फ्लूइड कंजम्पशन और इलेक्ट्रोलाइट लॉस की वजह से पेशेंट की बॉडी डिहाइड्रेटेड रहती है। अगर इस दौरान पेशेंट अच्छे से हाइड्रेटेड रहे तो वो जल्दी रिकवर हो सकता है।
मम्मा मैंने बोला था ना।
Shall I start? Yes, sir. Good evening, everyone. Welcome to the 52 weeks Diabetes Essential with Dr. Sanjay Kalra and in the loving memory of Dr. K.K. Agarwal. Today being a special occasion of International World Free Diabetes Day and 75th Independence Day evening, I welcome you for the special episode we have today with Dr. Julio Rosenstock. For this session, we have our moderator, Dr. Sanjay Kalra. I take the pleasure and honor of introducing Dr. Sanjay Kalra. Dr. Sanjay Kalra is a DM endocrinology from the prestigious Institute of AIIMS, Delhi. He is a consultant and director of Bharati Hospital, Karnal. He is a past president of Endocrine Society of India. He is a board member and chairperson in Education Working Group of International Society of Endocrinology. He is a president, Indian Professor Association of Transgender Health. This is IPATH, section editor of endocrinology, which is Association of Physicians of India, textbook of medicine. He is a section editor of tropical endocrinology, Endotext, the PubMed Index textbook. His hobbies are traditional Haryanvi Mudgar and Bhangra. I welcome Dr. Sanjay Kalra and hand over the session to Dr. Sanjay sir. Over to you, sir.
Thank you, Mr. Basu, and warm greetings to everybody who is logged with us today. First of all, heartiest congratulations for Azadi Ka Amrit Mahotsav, for the 75th independence anniversary that we are celebrating tonight. Celebrations and best wishes also for the second World Pre-Diabetes Day. World Pre-Diabetes Day was conceived and conceptualized and actually implemented by the Endocrine Society of India last year for the first time. And this year, what we see is that there's a lot of interest in this day. The International Diabetes Federation has also celebrated or observed this day today. Because it's a special day, we have with us a special guest, and I'd like to warmly welcome Dr. Julio Rosenstock. Warm welcome, sir. Dr. Rosenstock is director of the Velocity Clinical Research at the Medical City, Dallas, and he's also clinical professor of medicine at the University of Texas, Southwestern Medical Center in Dallas, USA. He has studied in Costa Rica, in the United Kingdom, and in USA. So he brings to us the best of all continents. An Indophile, he has been in India so many times. His knowledge of Indian geography is much better than mine, actually, to be honest. And not only is he an expert in Indian geography and history, he is also an expert in being proactive, in being active, in trying to manage diabetes. Now, when we meet experts, people who work in diabetes, most of us are very good at stating problem statements. For example, these are the challenges that we face in India. These are the challenges that we face in the USA. So we're all good at writing down our problems. Some of us are good at theoretizing also. Like some of our politicians, for example, we do know the theory that this shouldn't be done, that shouldn't be done. But then what actually is the solution? There we don't have an answer. We don't have a practical answer. But Dr. Rosenstock, we have this book in India. Our philosophy depends upon that. It's informed by that, and that is the Bhagavad Gita. The Bhagavad Gita is a poem, actually. It's a poetry where Arjun, who is one of our warriors, he goes to Lord Krishna and he says, God, I'm in trouble. What should I do? So the answer that he gets is that either you can do what is known as Gyan Yoga, that is theory. Gyan means knowledge. Or you can do Karam Yoga. Karma, you know the English word karma that comes from Karam. So Karma Yoga or Karam means action. That means practice. Lord Krishna tells Arjun, both are good. Gyan Yoga and Karam Yoga. That means theory and practice, both are good. Then Arjun turns around and he says, Lord, you've told me that both of these are good, but if I were to choose one, which would that be? And then the answer comes in the Bhagavad Gita that Karam Yoga or karma or action is better. Action is preferred to theory. With us today, dear friends, we have a karmic personality, a person who believes in karma, and that is Dr. Julio Rosenstock. Because when you see his clinical experience, when you see his research, when you see his writing, you will find that he actually walks the talk. He doesn't limit himself just to Gyan or to theory. He actually goes into practice, into pragmatic mode. And that is what he'll be speaking to us about today. Dr. Julio, we welcome you warmly back to India, and we hope to have you with us physically in the near future. You have so much of expertise and so much of evidence that has come through your research, so much of knowledge that has gone through your pen. Today, you'll be talking to us about challenges in type 2 diabetes and how to be more proactive and how to actually follow that Indian philosophy of Karma Yoga instead of just mere Gyan Yoga. Warm welcome, sir, once again, and the floor is yours.
Thank you so very much, Dr. Sanjay. Yeah, it is a real pleasure, and I really enjoyed your introduction. It is I like that. I like, because in life we need to be pragmatic. I think that we have to have a good sense of why we're doing things. It's always important to understand why we're doing things, but it's also important to be pragmatic and be down to earth in what we're trying to accomplish, and always trying to move the needle in the right direction. So I thank you very much. Thank you, the organizers, for the kind invitation. It's always a pleasure to share my experience with the people in India. I love the country. I've been many times there, and I wish next time we can do it face to face and have that direct contact. So my task today is trying to challenge the treatment guidelines for type 2 diabetes and emphasize the importance of simultaneous combination therapy from day one, right from the beginning, because I do think that we have the need to move that goalpost towards diabetes reversal or remission. And as you will see, we now have the tools, and we not just have the tools, we also need to learn how to implement what we're doing. And so in terms of implementing, I just want to challenge this paradigm for initiation therapy in type 2 diabetes, which is very critical. But before I start, I just want to wish you everyone a very happy Indian Independence Day in advance. I know that you will be celebrating tomorrow, and I join you and salute you for the celebration, and will deserve Independence Day to move on. So this is my disclosures. I've been fortunate to be involved in many clinical trials and the development of new agents, and being able to give some input in those trials. And I'm going to give you my perspective of what I've learned over the years to try to synthesize what the direction that we need to move. So when we looked at this challenging the paradigm for initiating therapy, I have to have certain premises why we're doing this. And first, we need to recognize that we have barriers to advanced therapies in type 2 diabetes. We have multiple choices and treatment complexities. We've learned from Ralph DeFronzo that we have an octet, multiple factors that they interact in diabetes, type 2 diabetes. We have increased lipolysis, increased glucagon secretion, reduced glucose uptake. Fundamentally, we have reduced insulin secretion. We have increased glucose reabsorption. We have defects in incretin function, increased hepatic glucose production. And what is it that we have done over the years? What the recommendations of the different guidelines say? Well, they say start with metformin. But if we're going to start with metformin, it's just very naive what we've been doing over the years. Because metformin alone or late addition of a single agent to metformin just cannot correct all the pathophysiology disturbance in type 2 diabetes. We have now incretin therapy, GLP-1 receptor agonist, GIP has a play role, DPP-4 inhibitors that have effects at multiple levels. We have SGLT2 inhibitors, as you know very well, that it reduces the glucose reabsorption and improves hyperglycemia, and indirectly also helps with the insulin secretion. And then have, of course, insulin that works at all levels. So my premise today, what I want to convey to you is that we need a much earlier treatment paradigm with simultaneous use of metformin plus an SGLT2 inhibitor plus minus a GLP-1 receptor agonist. That is what I think, and I'm going to give you the rationale why I believe that we need to be more proactive in multiple combination therapy right from the beginning to tackle these multiple factors in type 2 diabetes. And what's happened over the years? We've been moving from a glucocentric to a more cardiocentric guidelines, but it's still in a sequential fashion. We, as we'll discuss later, we have drugs that they act on cardiovascular benefits, and that's why the ADA, the consensus in 2019 emphasizes that when you have established cardiovascular disease or risk factors, you have the use of GLP-1 receptor agonists or SGLT2 inhibitors. And if you have evidence of heart failure or evidence of renal dysfunction, and SGLT2 inhibitors, as we'll discuss later. And if the A1C is not well controlled, then you have the option to add on in a sequential fashion to these medications, to metformin and so on, a GLP-1, a DPP-4, and so on, depending on if you want to avoid hypoglycemia, promote weight loss, and so on and so forth. But what is it the common thing that we've been doing for years? What it is that the common step-up principle has been start therapy with metformin first, and then sequentially add on therapy according to the HbA1c levels. And yes, we have become more prescriptive because, as I said before, we can give a SGLT2 inhibitors and a GLP-1 receptor agonist for cardiorenal protection if people are at high cardiovascular risk or evidence of chronic kidney disease, regardless of HbA1c level. So if you have anybody with evidence of coronary artery disease or heart failure or risk factors there, you can do that. But the question is, the critical question is, with these more personalized, but still sequential ADA-ASD recommendations lead to a better glucose control and less clinical inertia. And what happened is, what is the definition of insanity? Insanity is doing the same thing over and over again and expecting different results if we do it in this sequential fashion. Because what happened is that we have this clinical inertia that you know very well, that people just don't do it, despite the fact that the guidelines said that you have to check your A1C, and if the A1C is above the target level, then you keep adding medication in a sequential fashion. But what happened? Look at the United States. Despite all the financial strength and all these things and resources, look at that from NHANES data from the National Health and Nutrition Examination Survey. You can see in the trends in diabetes treatment there. You have people having A1C less than 7%, 56, 57%, and actually came down in 2015, 2018, despite all the different resources, despite all these new medications. Why? Because of clinical inertia. People just don't do this sequential treatment. And so what is the rationale for giving simultaneous combination therapy in type 2 diabetes? And I'm glad to talk to the Indian people, because in India, you guys do a lot of combination therapy. You have multiple agents that they work in combination therapy. And so what's the rationale? What are the logical expectations? Well, when we do combination therapy, we want the components that should exhibit complementary actions. It's logic. And the glycemic control should be better than with each individual component when you use two of them. The combined dosages may be lower than each individual component alone. The side effects should not be increased and ideally be mitigated. And also the treatment that way is simplified and may improve adherence and persistence. The cost should be lower than the sum of the costs of each individual component, because if one costs 10 and the other costs 15, then instead of 25, they cost 18 or less. So the cost should be less. And the earlier, the better the chances of attaining and sustaining glycemic targets, as I'll show you later. So the concept, one thing that the best proof of concept for early intervention with combination therapy comes from the Verify trial, which I take it as a proof of concept. This is a study that was published in The Lancet a few years ago with my friend David Matthews and Stefano Prato. They looked at the glycemic durability of early combination therapy with vildagliptin and metformin versus sequential therapy. So what they did is they took people with early type 2 diabetes, recently diagnosed. They started them on metformin over a 3-week period, up to 15 milligrams. And then if the A1C was between 6.5 to 7.5%, which is very good control in general, they went randomized to add metformin and a DPP-4 or continue with metformin alone. And so the idea was to give the metformin plus vildagliptin or DPP-4 as an early combination versus metformin as a monotherapy alone as a placebo. So they were followed, and if they failed, they still continue metformin and DPP-4. If it not failed, they continue the combination therapy. So they continue with the combination of the two to see how they progress. And if they were on metformin and not failed, continue with metformin alone, or if they failed, then they add the DPP-4. So what they did, how they assess the treatment is the time to failure defined as an A1C above 7%. Remember, they started between 6.5 and 7.5. And the failure is if you get two A1Cs above 7%. So you can only confirm that after 6 months. Let's say they got the A1C above 7 at 3 months and then at 6 months. And you can see there, or if the first time of an A1C was above 6 months, then you confirm at 9 months. If you're very well controlled, then you continue with whatever you were, with metformin and DPP-4 or metformin alone. Those are not failure. So what happened? Here you have the initial monotherapy. You like appreciate that already at 6 months, almost 20% have been already above 7%. What happened there with those people who were on combination therapy from day one? You can see that the early combination therapy, you can appreciate there was a 50% reduction of the progression. So at 3 years, you can see that monotherapy alone, metformin alone, 50% of them are above 7%, whereas 25% were above 7% with the combination therapy. It was a reduction of 50%. And even at the 5 years, you can see that you continue with better control in more than 50% were below 7%. So if this was with a combination of metformin and a DPP-4, one can assume if it worked for metformin and DPP-4, it should work for metformin and an SGLT2 inhibitor or metformin and a GLP-1 receptor agonist. So we can have a better control, sustained control right from the beginning. And the other important reason to use the SGLT2 inhibitors or GLP-1 receptor agonist is because we have cardiorenal benefits. I'm not going to go over all the data, but you're very familiar with the cardiovascular outcome trials that they have been performed because the FDA wants to show that the new drugs are neutral. They don't produce problems with cardiovascular, but if anything, they actually show the benefit. You can see that with the GLP-1 receptor agonist in the 3-point MACE with cardiovascular death, MI, and stroke. You can see that, for instance, LEADER with liraglutide, SUSTAIN 6 with semaglutide, EXCEL with the anyway, HARMONY with the albiglutide, Rewind with dulaglutide, Pioneer 6 with oral semaglutide, Excel with exenatide, Pioneer 6 with oral semaglutide, Amplitude O with efegenatide, you can appreciate that you have a 14% reduction of MACE, cardiovascular death, MI, and stroke. So those drugs used early can reduce the cardiovascular problem, which is a major cause in diabetes. Same thing with the SGLT2 inhibitors. Look at that with the EMPA-REG outcome, Canvas program with canagliflozin, Declare with dapagliflozin, and Vertis with atugliflozin. You can appreciate with empagliflozin, you have a reduction of heart failure, 35%, reduction of cardiovascular death, 38%, triple MACE was reduced, renal outcomes, it was slow the progression of the kidney disease by 46%. Empagliflozin, canagliflozin got the same effect on heart failure, triple MACE, in the renal outcomes, did not show cardiovascular death. Dapagliflozin, also consistently reduction of heart failure and benefits on renal outcomes, in ertugliflozin with the heart failure. So you can see that the common denominator here is that they have very consistent benefit on heart failure and renal outcomes. So what are the ADA 20 recommendations currently? It's just that if you have evidence of cardiovascular disease or high risk factors, you can start with a GLP-1 or SGLT2. If you have a heart failure, you give an SGLT2. And you have evidence of chronic kidney disease, same thing with an SGLT2 or a GLP-1 receptor agonist that have shown benefits. And then what I mentioned before, if you need to minimize hypoglycemia, you have the drugs there, DPP-4, GLP-1, SGLT2s, and TZDs that don't produce hypoglycemia. Or if you want to promote weight loss, a GLP-1 receptor agonist or SGLT2, and it costs the sulfonylureas and TZDs. But the point that I want to emphasize, the really point that I want to emphasize, is that people with high cardiovascular risk, you don't need to wait until people develop a coronary artery disease. Because if you have type 2 diabetes, you probably have, you're overweight. You also have dyslipidemia. You have hypertension. Those are risk factors that get you at a high risk of having events. That's why the European Society of Cardiology came up a few years ago to say that you don't have to wait to start metformin first and then give any of those GLP-1 or SGLT2 after metformin. You just go ahead and start metformin right from the beginning. And subsequently, if you need metformin, you can give it there. And then the same rationale of adding medication. And the point here is very important because that makes the point that initial combination with metformin and SGLT2 and a GLP-1. People were saying, well, have some concern that why should you start an SGLT2 before metformin? Or why should you start a GLP-1 before metformin? And I said that people who have this discussion in some of the ESD have some issue there, that why you should always start metformin first. So I say, don't waste time in this discussion. Just go ahead and use combination therapy from day one with metformin and SGLT2 inhibitor or GLP-1 receptor agonist. Why is that? Look at this meta-analysis from my friend Darren McGuire that looked at, for instance, for cardiovascular outcomes in SGLT2 inhibitors. People who have evidence of atherosclerotic cardiovascular disease, people with no atherosclerotic cardiovascular disease. You still have the same benefit, even if you don't have established cardiovascular disease and you only have risk factors. It does work, reducing the risk of heart failure. When you looked at kidney-related outcomes, it's the same thing, whether you have atherosclerotic cardiovascular disease or no evidence of atherosclerotic cardiovascular disease, and you only have risk factors, you also reduce the chances of progression of the kidney disease by 40%. So this is very critical. And the same is true for GLP-1 receptor agonists. Look at dulaglutide in Rewind, where they have 60%, almost 69% of the people who have only cardiovascular risk factor. You can see there that this is the reduction with the overall, but when you have prior cardiovascular disease or no prior cardiovascular disease, still you have the benefits of the cardiovascular benefits. So what's been the traditional sequential or early combination therapy? Here you go, you start with diet and monotherapy titration, or the combination, and so on. Then you say, over the years, we've been saying for years, okay, let's go with early combination therapy, but it's still starting with monotherapy and then adding combination therapy if it's about 7%, and then up titration, and then basal insulin, and so on. But the point that I want to convey to you is that we need to move the needle. And for that, I believe that we need to start much earlier with lifestyle changes, but metformin and SGLT2 inhibitor. Why I choose an SGLT2 inhibitor? Because it's a pill. It's easier to give a pill. And this is from Eugene Brownwell, who wrote this editorial that he thinks that SGLT2 inhibitors are the statins of the 21st century. He actually, this is the professor of cardiology for Harvard there, who compares the statins to the major changes in medicine like aspirin, penicillin, and statins. So no reason why we should not use that in combination therapy right from the beginning. Or you may decide to use an oral GLP-1 receptor agonist if you have it available, like oral semaglutide. Or the ideal is to use a triple therapy, metformin, SGLT2, and an oral GLP-1. Or you may want to use metformin, SGLT2, and a weekly GLP-1 receptor agonist, or as I show you, a GIP GLP-1 receptor agonist like tirzepatide, and then at the end, use basal insulin. We even are working now in a weekly basal insulin. So how nice is it going to be where you can give a weekly basal insulin, a weekly GLP-1 receptor agonist to simplify the treatment. So what is the evidence for this early combination therapy? So I show you this initial dual metformin plus SGLT2 inhibitor as a first-line therapy. This is a study that we published several years ago where we did the combination of empagliflozin plus metformin in people who were drug naive. And you can see that these are people who were on empagliflozin alone or metformin alone. You can have a nice reduction with monotherapy, 1.8, 1.2, so that's good. But if you use empagliflozin plus metformin in different dosages, you can see there that you can actually get below 7%. With monotherapy, you don't. Or if you do, it's going to be temporary. Here you can see clearly that in terms of efficacy is much superior. Or you can use an oral GLP-1 receptor agonist if available, like oral semaglutide, and there are several now in development. Like for instance, this is a study that we published a couple of years ago, Pioneer 1, also to create people with compare oral semaglutide monotherapy in people with drug naive, and you can see there with oral semaglutide, you can have reductions down to 6.4%. And the nice thing about that is that it's associated with a significant weight loss with the oral semaglutide there in terms of the A1C reduction up to 1.5% in 4 kilos weight loss. And you get down to 6.4%, which is very, very significant. So it is highly conceivable, I believe, that simultaneous initial therapy oral semaglutide and metformin would have induced even greater A1C reductions and weight loss. This is only oral semaglutide alone. But if you use it, you would have used it in combination with metformin. I bet that the A1C would have been greater and the weight loss even greater. So there's been several recommendations to use combination therapy by different organizations. ACE, American Association of Clinical Endocrinology, the Latin American Association, the Canadian, the ADA. I'm sure that the Indian Association has different recommendations. I believe we don't need to be guided by A1C. Like the recommendation says, if the A1C is above 2% of what your goal is, or 1.5% above your goal is, regardless of the A1C, I think that it is highly conceivable that initial therapy with a combination of metformin and SGLT2 inhibitor and or oral GLP-1 receptor may become the preferred treatment for newly diagnosed type 2 diabetes regardless of A1C levels. So what about the weekly GLP-1? If you want to use a more potent drug, you can use a weekly GLP-1 receptor agonist. This is a study, for instance, with semaglutide in people who were drug naive, and you can appreciate that with semaglutide, you go from 8% to, again, 6.5%, associated with a significant weight loss of 4 or 5 kilos there. And so that is something that you can also use as an option. So with these tools, we can start moving the goalpost towards reversal or remission of type 2 diabetes with weight loss. And so what are the benefits of weight loss? Why do we insist on that? Well, if you have 5% body weight loss, you actually have benefits on liver insulin sensitivity, reduce the liver triglycerides, improve beta cell function, and reduce abdominal adipose tissue. If you have a 10% weight loss, you actually have a more potent effects there in terms of reducing insulin resistance, removing the fat from the liver, and so on. And 15% is even more robust and very important for diabetes remission, as I'll show you in a minute. But what is the definition of remission or reversal of diabetes? Well, so last year there was this consensus report of trying to define diabetes remission. And the definition of diabetes remission was, this group defined remission as the most better description is if the A1C becomes less than 6.5%, measured at least 3 months after cessation of glucose-lowering drugs. So they say, if you've been on with type 2 diabetes, you have medications, you get the A1C below 6.5%, and then you stop them, and they continue below 6.5%, you achieve remission. Well, that's the concept with bariatric surgery, but not with oral agents. Actually, I criticize this definition because you're not going to get below 6.5% and then stop the medicine. You do that in the concept of a clinical trial to see what is the effect of the drug on and off. But in real practice, you won't stop that. I think that this point of reducing A1C to 6.5% and stopping the medication just doesn't make sense. We need to redefine diabetes remission using the oncology concept. God forbid you have cancer. What the oncologists do, they give all these multiple therapies, they get the cancer under control, and then what they do maintenance therapy. You maintain the patients free of cancer or whatever, and but with maintenance therapy. So we should borrow and apply the practical concept of achieving remission in diabetes from the cancer medicine and pursue short-term intensive use of drugs, glucose-lowering drugs, weight-lowering drugs, targeting multiple pathways and achieving meaningful body weight loss to attain reversion of the to normal glycemic metrics with maintenance therapy as needed. For instance, with semaglutide, with high dosages, they actually, semaglutide for diabetes is approved as up to 1 milligram or 2 milligrams. But Novo developed semaglutide up to 2.4 milligrams. And you can see in this step 2 therapy trial with semaglutide 2.4 milligrams in people who are overweight or obese and having type 2 diabetes. Look and see that you get a reduction from 8% A1C, you reduce by 1.6%, very robust reductions, and you have almost 10% body weight loss. It's very important. You can see that 77% of people got an A1C 6.5% remission, defined as an A1C less than 6.5 or 6.4%. And when you looked at people having an A1C less than 7% with 10 with 10% or 15% weight loss, you have a significant number of patients. Tirzepatide is the newest drug, which is very impressive, just recently approved in the United States by the FDA. And you can see that in a study that we reported in the Lancet, the Surpass 1, where we took people who have this, by the way, tirzepatide is a novel dual GIP and GLP-1 receptor agonist that is called tirzepatide. We did this in people who have type 2 diabetes in drug naive. And you can see there that we took people who had an A1C of 8%, and we got it down to 5.9%, which is impressive. 5.9%, below 6%, which is numbers that we never dream about getting. And this is most importantly, you know, if you look the conventional, less than 7%, almost 90% got there. A1C less than 6.5%, 86%, 81% got there with the tirzepatide 10 and 15 milligrams. But most impressive is the fact that 52% of people got an A1C of 5.7%, which was normal. That is the definition of normal glucose. And you can see that was also achieved with a body weight loss of around 10 kilograms, which is most impressive. And this is a very consistent result. You can appreciate that the body weight changes from baseline. It was around 10, 12 kilograms, which is almost 11, 12% the body weight loss, which is very impressive. Whether you do this with this tirzepatide GLP-1 GIP receptor agonist in a study where it was like we reported in Lancet in people with monotherapy, or when it was add-on to metformin, or add-on to metformin and SGLT2, or triple therapy, or even added to a basal insulin. Consistently, you get superiority against a GLP-1 receptor agonist, against another GLP-1 receptor agonist, and so on. And when we looked at the different trials, what percentage of people got 15% of body weight loss? This is the study that we report in the Surpass 1. This is the Surpass 2 versus semaglutide. 40% got that body weight loss of 15%. This is study versus degludec. 43% had a weight loss of 15%. And you can see that 30% got that weight loss of 15% body weight when you add it to insulin glargine. Why I say 15% is important? Because this epidemiologic study in Scotland showed that people who have lost 10 to 15% have greater chances to get into remission. And that means that if you lose 10 to 15 kilograms, you have a much better chances to achieve remission, reversion of type 2 diabetes. And as you can see in the tirzepatide clinical trial, you can appreciate that 50% of people get A1Cs less than 5%. That for me is remission. That for me is going down to normal glucose control. These are studies in type 2 diabetes. Now, they also are developing this drug for obesity. And just a couple of weeks ago, there was this study in New England Journal of Medicine, Surmont 1, they had showed robust weight loss in overweight obese people. And you can appreciate that they lost 21% of body weight with the higher dose of tirzepatide, 15 milligrams, 19 to 20% of body weight loss, which is a really wow result. And if you look at different way to analyze the data, in an estimate, 22% of people lost 22% body weight loss. But the most impressive thing in these overweight people, 41% of these overweight people had pre-diabetes, and 95% of these people with pre-diabetes reversed to normal. So not just that we can reverse type 2 diabetes to normal glycemia, we can now prevent the development of type 2 diabetes in people with pre-diabetes when we really tackle the weight problem. So my last word is, as I said before, we should borrow and apply the practical concepts of achieving remission from oncology medicine by utilizing simultaneous combination of drugs that target multiple pathways and achieving meaningful body weight loss right from the time of onset of type 2 diabetes to attain reversion to normal glycemic metrics with maintenance therapy as needed. So I would say that these new glucose-lowering drugs with robust weight loss efficacy have moved the goalpost for type 2 diabetes, management towards attaining diabetes reversal or diabetes remission, which may no longer be, as they say from Don Quixote, the impossible dream to reach the unreachable state. This is like they say, the karma that Dr. Sanjay was saying. I think that this is the yoga karma. I try to be as practical as possible. We have wonderful tools, new tools. We just need to use it better in combination therapy. And I stop here and I take your questions, and I really thank you for your attention and the pleasure to communicate with you all. And I hope that next time we'll do it face to face. Thank you very much.
Thank you, Dr. Julio. That was a great presentation. And thank you especially for your clarion call to focus on karma. We have doctors logged in from across the country, and you'll be amazed as to the number of questions that you have. I just hope that we are able to take all of them. And Dr. Julio, these questions, they're limited not only to your topic for today, they sort of encompass the entire spectrum of diabetes care and beyond. So I hope you're game for that.
I'll try.
We'll try together.
Yeah, we'll try together.
Yep. So lots of questions coming in and lots of comments and appreciation also for your talk and the way you've been able to explain. Specifically, we have comments saying that your accent is easy to understand and your speed was perfect, your diction was perfect. So thank you for speaking slowly for us.
Thanks. Sorry for my accent.
Oh, no, but that is perfect. It is perfect. There is a question. The first question actually has come in from Dr. Mahendra Sharma. He talks about hydroxychloroquine. So if you allow, let me take that. Hydroxychloroquine is approved as a glucose-lowering drug in type 2 diabetes in India, but not in the US. We do not use it, Dr. Sharma, as a first line or second line or third line drug. But in case you have a patient with diabetes and with polyarthralgia, arthritis, rheumatoid arthritis, where otherwise you're thinking of whether to give HCQS or not, then when you have both these indications together, I also write them. Another situation where I prescribe hydroxychloroquine for a short period of time is people with type 2 diabetes who present with the post-dengue or post-chikungunya arthralgia. And that can be a very painful and debilitating situation. It works very well there. I have used it in a few people post-COVID as well, people who present with arthralgia post-COVID. And there again, the drug is effective. Of course, when you're using it as an anti-arthralgia drug, the dose is usually 200 milligram BD. If you want to use it for diabetes, then 400 milligram OD or 400 milligram BD is what is preferred. The A1C will not come down by more than 0.5 or 0.6%. So it's not going to, create magic. Sir, a question coming
very
from
interesting. Thank you very much. That's very interesting because there was so much controversy about that with the use of COVID when we didn't have any medication.
Yeah.
I think in the United States, they're only using people with lupus.
Yes. Dr. Khan, Dr. Javed Iqbal Khan has a question. What do you monitor in your practice? Fasting glucose, postprandial glucose? Do you do a structured glucose monitoring, paired glucose monitoring? What is it that you do when you have patients on oral glucose lowering therapy?
I think that there's no question that the A1C is the gold standard. The A1C is the gold standard. I think that we now monitor that, and conventionally we want to get below 7%. But I think that now with the new tools, we can get it as low as possible without hypoglycemia. So we monitor the A1C. Obviously, when the patient comes to the office and the fasting plasma glucose gives us an idea. In people with type 2 diabetes, I do not chase postprandials because it's too invasive, it's too much burden on the patient. Obviously, if you have available CGM, it could be very helpful. Like for instance, you have the Libre which is much less expensive there. You can do some intermittent CGM, so that gives you a profile where you can make some decisions. But if you're on oral agents, it is very debatable. The expense of the CGM is not justified. I think that you need to go mainly by the A1Cs. The fasting is something that is very valuable when you are using basal insulin to titrate the basal insulin.
Dr. Javed, most of us do continue glucose monitoring. And a difference between us and the US is that here glucose monitoring is quite economical in India. You can do self-glucose monitoring, and you can also go to the laboratory. So it is direct access, and maybe in around 25 or 30 cents, you can get a glucose done.
Wow, that's very good.
Yeah. So a rough target for most of our patients, Dr. Javed, would be a fasting of maybe 70 to 130 milligram%. We use milligrams here, roughly 100 milligrams. And a postprandial of 140 to 180 milligrams. This would be for the average adult. If you have someone who is planning pregnancy, planning conception, or is pregnant, then the glucose levels do come down, the targets come down. If it is an elderly person with nephropathy, autonomic neuropathy, hypoglycemia unawareness, then you can relax the targets.
Well, it's good, Dr. Sanjay, that you are using CGM there. Because if you're using CGM, then you can use other metrics like time in range. So you want the time in range between 70 and 100 and 80 to be 70% of all the blood glucose measurements. Yes. So that's what you need to be. And if you can get it better than that, that would be great. But the time in range will be very valuable. You want this to be at least 70%. And then if it's about 180 and so on, you want it to be less than 20% and so on and so forth. So you can individualize, but if you're using CGM, that helps you continue adjusting the medicine. The thing is, the important is to use it in a proactive fashion so people can intervene. And the other thing when you use CGM, patients learn what kind of things will raise the blood glucose, so it helps them with the diet and so
on. That is true. CGM, AGM, time in range, these are called theranostic tools. They're not only diagnostic, they're also therapeutic, because when the patient has applied a CGM or an AGM on himself or herself, the patient is, of course, diagnosing, monitoring what's going on, but is also learning and is able to tweak his or her therapy accordingly. So it is a theranostic tool. A question from Dr. Ashutosh Das, and he takes you up on your statement. So Dr. Julio, you said that whatever we are doing is to prevent complications, and that is right. How early should we intervene? This is Dr. Ashutosh's question. At the time of pre-diabetes, on the day of diagnosis, when do we intervene? What is timely?
I think that we don't have enough data with the pre-diabetes intervene because you have pre-diabetes, you're going to treat. Obviously, there is a recommendation of use metformin in people with pre-diabetes when there's a strong family history of diabetes. When there's strong family history of diabetes and you're obese, or in women who have a history of gestational diabetes and they have pre-diabetes subsequently, there is rationale for metformin. But if you have an approval for obesity and you want to tackle the overweight, and is recommended for overweight, people who have pre-diabetes will certainly revert to normal. I think that, as I said, and I emphasize, I think that when you diagnose type 2 diabetes, you already have several years of type 2 diabetes. When you diagnose type 2 diabetes, it's been silent for several years. And some of those people had already for quite some time. And if they're overweight, and if they have dyslipidemia or have mildly elevated blood pressure, those are risk factors. So that's why I emphasize from day one, we need to use a combination therapy. And if you can afford to use metformin and SGLT2, fine. If you can afford to use a GLP-1, fine. Whatever you choose to use, whatever the patient can afford, and whatever the patient can tolerate.
So a very strong message and very well taken. Day one is the day that you will intervene. And we must understand that most of our countrymen and women already, they come to us when it's too late. I mean, as it is, there's a long delay between the onset of disease and the time that they present to us. So day one is the day that we begin, and we should try to preempt day one as well by by strengthening our screening programs across the country. Dr. Jadav Bhagwan Ramrao says, you've spoken about obesity and diabetes. Suppose somebody has obesity, diabetes, and polyarthritis. Would that make a difference? Would arthralgia, arthritis make a difference to choice or preference of any glucose-lowering therapy?
Oh, that is a great point. Actually, now with these new drugs, with both semaglutide 2.4, which was approved in the United States, and it's called Wegovy, they're so widely used that actually they run out of medications and so on. And tirzepatide also has a program for obesity. They have already in the books studies where they are looking at the effect of weight loss on osteoarthritis and knee pain. And so any orthopedist will tell you when you have knee pains or osteoarthritis, I think that is going to have a tremendous benefit. The other area that they are looking at with this weight loss is that we didn't discuss it, NASH, because I mean, a lot of these patients, 40, 60% of people with type 2 diabetes, even 70% have NFLD, non-alcoholic fatty liver disease. The other area, for instance, that this weight loss is for sleep apnea, which is another thing that they will have tremendous benefit.
Right. And there is a theoretical possibility that DPP-4 inhibitors might worsen polyarthralgia. If your patient is on DPP-4 inhibitors and you feel the arthralgia has worsened, there's no harm in stopping for a week or two to see what happens. But that is more theoretical, and it's not that we see it every day in practice. Dr. Suhas More shares a clinical case with you. Young 32-year-old young male, newly diagnosed with diabetes. The HbA1c is quite high, 11.9, and the BMI is 23. BMI is not raised. There's a strong family history of diabetes. So the question from Dr. Suhas is, what other types of diabetes should I consider in the differential diagnosis? And what are my treatment choices? What should I prefer?
Well, if the patient is symptomatic, with an A1C of 11% and has a low BMI and with history of weight loss, I will certainly start the insulin. I think that this patient needs to get reduce that glucotoxicity, get it under control. I'm sure that they are going to regain some weight loss and so on. This patient can have an evolving type 1 diabetes. I think that measuring a C-peptide will be beneficial to get an idea whether or not they have C-peptide. You can also measure gut antibodies and so on if you have available to see whether or not it is a type 1 diabetes that is evolving. But we've seen some patients who have very chronic hyperglycemia over time. If the patient is asymptomatic, if the patient feels fine and so on, and is resistant to start insulin, I will start in combination metformin. Even a sulfonylurea will be a combination metformin, sulfonylurea. There will be an option because sulfonylurea will work really fast. But I will give insulin to this patient and try to get it under normal and follow them. Some of those patients, once they get normalized, then you can put it on combination of metformin and SGLT2 in a GLP-1. Well, you may decide not to use the GLP-1 because of the body weight, but see if you respond. If you bring the A1C down, you put him on metformin and an SGLT2, and it tolerates an GLP-1, but let's say metformin and SGLT2, and even a sulfonylurea, and see how it responds. If they remain with hyperglycemia, well, the patient has type 1 diabetes. So I understand that type 1 diabetes is not that frequent in India, but there are plenty of type 1 diabetes, so that patient may have.
Type 1 diabetes is fairly frequent, fairly common in the country. And we have a gradient, actually. It is a latitude gradient. So the further you move from the equator,
oh, really?
The more you see the frequency of type 1 diabetes, celiac disease, other autoimmune diseases as well. So as we move towards the north, the incidence and prevalence of autoimmune diseases does go up. Apart from type 2, lean type 2 would be our first differential with what Dr. Suhas has given us. We should rule out type 1. We should also rule out MODI, which is fairly common in the country.
Of course.
Yeah.
And
Maturity onset
that's
diabetes
why the sulfonylurea could be very, very useful.
And also pancreatic diabetes is something you must see. It is limited to a few pockets of the country and a few ethnic groups. But do think of pancreatic diabetes. The least we can do is to take a history of malabsorption, to take a history of abdominal pain, a history of steatorrhea, history, and look for malnutrition. And if required, you do an X-ray or an ultrasound of the abdomen. Dr. Iqbal has a question, Dr. Iqbal Khan, and he says generic versus branded drugs. This is a debate which goes on in India. So his question is, does the same debate exist in the US? And what is your take on generics versus branded generics versus originators?
Well, I can tell you that my Lipitor, it comes from India. My atorvastatin comes from India. My blood pressure medicine comes from India. So it is what it is. I think that there these days are very good quality control and so on. And I don't have any problems with the generic medications as long as they have very good quality control. So I take my statins come from India and my ACE inhibitor comes from India. So I have no issue with that.
And metformin also, I think India contributes to about, a single Indian company contributes to about 60% of the global metformin usage.
Yeah.
So thank you, Dr. Javed, for raising that point, and thank you, Dr. Julio, for answering that as well, especially on the eve of our Independence Day. India is known as the pharmacy of the world. A question from Dr. Anshul. Dr. Anshul Singhai is a dynamic diabetologist based in Chhattisgarh state. He has a few tough questions for you, sir. The first one is, the ominous octet is fine, that has its own place. But let's just talk about beta cell insufficiency and insulin resistance. If it is beta cell insufficiency or insulin secretory defect, which is going to precipitate diabetes, what he means is that insulin resistance was there even earlier. Alone, it was not enough to precipitate diabetes. Then if that is so, then why don't we just start with insulin as a first line therapy? Is there a school of thought which propagates that?
Yes, there is a school of thought. I mean, it's a very interesting point. There is some studies have been conducted in China and also in South Korea, where they have taken people with newly diagnosed type 2 diabetes with hyperglycemia, given the intensive insulin therapy to maintain normal control, complete normal control, and then they stop the insulin altogether. And then people remain with, for several months, even up to 1 year, a good percentage of them remain with normal glycemia. What that means, it means that the glucotoxicity by itself is impairing the insulin secretion. And when you eliminate the glucose toxicity, you improve the beta cell function. Now, you can actually, with the same rationale, mean that, yes, that's a strategy that you can have. Patients are reluctant to do that. But now you can do the same thing with a GLP-1 receptor agonist. With a GLP-1 receptor agonist, what are you going to do? You're going to improve insulin secretion. You're going to reduce the glucagon secretion, the dysfunction with the glucagon, and you are going to improve beta cell function and also induce weight loss. So yes, I agree with the diabetologist in saying that the primary defect is beta cell dysfunction, basically, because there is a lot of people who are obese who have insulin resistance and they don't develop diabetes. They only develop diabetes when you have a beta cell defect. So, I mean, if you want to use insulin as a first-line therapy with the purpose of normalizing, that's fine, but that's a lot of work, and also have the risk of hypoglycemia, and also you're not going to have weight loss. You can achieve the same thing with a GLP-1 receptor agonist.
So thanks. So thank you, Dr. Anshul, for raising this point, and thank you for the debate actually that this sparks. So you do have a choice. We have exogenous insulin, we have insulin secretagogues, The insulin secretagogues can be directly acting, like sulfonylureas and repaglinide, the meglitinides. They can also be indirectly acting, like the GLP-1RA and DPP-4 inhibitors. So based upon what suits the clinical situation and what the patient prefers, you have a choice. And point well taken. Sir, a question for you from Dr. Jha. He asks if you have any experience in treating type 2 diabetes and psoriasis, and if there is any interaction between the
No,
anti-psoriatic
I don't
medication.
have any experience. There is an editorial with by Dan Drucker and his wife, who is a dermatologist, Rosen. So you can check it, Drucker in Lancet, because there is some anti-inflammatory effect with GLP-1 receptor agonists. And so apparently the GLP-1 receptor agonists may help some of those skin disorders, but I don't have any experience. So, but there is some theoretical rationale, and you can look for that commentary in Lancet by Dr. Daniel Drucker.
So thank you, Dr. Julio, for that point. A question from Dr. Shubham Yadav. What do you feel the future is for sulfonylureas like Lazide?
I think that, I was the PI of Carolina, the cardiovascular outcome trial Carolina, that it tested linagliptin versus glimepiride. And, the problem with the sulfonylureas is that there was all this concern over the years that they can increase cardiovascular risk. So in Carolina, we demonstrated that sulfonylureas do not increase cardiovascular risk. The problem with the sulfonylureas, as you said before, Dr. Sanjay, you can use it initially when you have somebody with significant hyperglycemia, and because they're going to act very quickly, they're going to increase insulin secretion and so forth. But over time, the effect disappears. The same thing is true with the DPP-4s. DPP-4s have less potent effect, but over time, the effect disappears. And the problem with sulfonylureas is they can induce hypoglycemia, and they also weight gain. So I think that we're going to use less and less and less sulfonylureas. But you can use it very specifically, like you said, in MODI, you can use it. You can use it as a short term to induce rapid improvement of hyperglycemia, but then you stop it. And for sure, you should not use sulfonylureas with insulin because it increases the risk of hypoglycemia. Should not use it in people with reduced eGFR.
Dr. Shah Alam Ansari also points out that MODI can easily be managed with diet, lifestyle modification, exercise, and sulfonylureas. And you will not need insulin for MODI. So thank you, Dr. Ansari, for raising that point. Dr. Nutan Davari thanks you for describing the new drugs and their mode of action. So thank you for putting all that in perspective for us. But Dr. Vishwas Bhapkar says, you've talked about drugs, but what about the mind? So his question is, does the mind cause diabetes? Can the mind be harnessed to manage diabetes?
Well, of course, mind controls everything. Mind controls everything. I mean, we have all the neurotransmitters and all this stuff. And after all, the GLP-1 receptors work in the CNS, controlling satiety and so on. I don't know if, you are the experts in yoga and meditation. I mean, stress worsens the hyperglycemia, but you have to have a really super powerful mind to control the A1C. But, I don't rule out. I think that all the yoga, all the meditation, all the things, lifestyle intervention, no stress, exercise, controlling that, is all part of
Dr. Julio, by chance, Dr. Vishwas's name, the word Vishwas in Hindi means belief. So his name itself is suggestive that if you believe in something, you can achieve it. And Dr. Vishwas, if you're interested in this, the concept is known as mind-body medicine or mind-body endocrinology. One of our torch bearers in the country is Madam Vaishali Deshmukh from Pune, and she will be holding a fellowship this month or next month. So if you are interested in learning more about mind-body medicine, please reach out to the FDC team and we'll put you in touch with Dr. Vaishali Deshmukh from Pune. But this is an upcoming field, both in the US and in India. And we can use the mind. We can use it to manage diabetes and also to prevent a lot of metabolic diseases. Dr. Deepmala has a question. Allow me to take that, sir. So, madam's question is, energy drinks, zero energy drinks, do they work in diabetes? So the answer is yes, but how do they work? First of all, there is evidence to show that drinking more water reduces the onset of reduces the risk of new onset hyperglycemia. How do you compare that? What are we comparing it with? The point is, if you drink more water, as opposed to wine, or as opposed to maybe carbonated drinks, then the risk of hypoglycemia will go down. Secondly, if you have a person with dehydration, that is quite common in India. It might be because of vomiting, it might be because of diarrhea, maybe just because of heat exhaustion. Then it is a good idea to replenish fluids and electrolytes. And if you have an energy drink, a zero-calorie energy drink, which can do that without increasing the caloric burden, that is welcome. So these are the situations where we use it. Dr. Anshul Singhai has another question, and he says, sir, you're a leader in world diabetes care. Now, earlier the guidelines were 7%, and we understand that the target was 7%. We understand that because of glibenclamide and metformin, we didn't have anything beyond that. Then we had the animal insulin.
We're getting.
Now we have SGLT without causing hypoglycemia. Why do we bring the target down to 5.7%? Because even above 5.7%, there is an increased risk of vascular complications.
I'm sorry, we got interrupted there with this sound. I could not hear everything. Can you hear me well? Can you hear me?
Yes.
But I did not get the
Carry on,
question.
Dr. Julio, we can hear you.
Yeah, you can hear me, but I could not hear you.
Yes, we can carry on.
Yeah, but I did not hear the question. Can you repeat the question? Hello? 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 Yeah, cannot, it is frozen. It is frozen. I cannot hear you. Basu, you have you.
Yeah, sir, we just lost the link from Dr. Sanjay Kalra. I understood
Yeah.
that, sir, you have also missed the question, and I am requesting Dr. Sanjay Kalra to repeat the question. If Dr. Sanjay Kalra is available with us. Oh, he's not there.
Dr. Sanjay. Yeah.
Sir, yeah, he has come back. So, Dr. Sanjay, Dr. Julio and we do not understand the question because we lost the link somewhere. Can you repeat the question, sir?
Sure, I'll repeat, and sorry for the technical glitch. The question from Dr. Anshul is, earlier our HbA1c target was 7%. And that is fine because we had the older drugs to use, which were quite dangerous. But now we have good quality drugs, which can achieve euglycemia without causing hypoglycemia. Why do we not bring the target down to 5.7%?
Well, because I think that this is something that you as a physician can individualize with the patient. The guidelines recommend to be less than 7% or 6.5%. What I showed there is I agree. I think that when you're dealing with an individual patient, you as a physician can get the A1C less than 6% or less than 5.7%. That's exactly what I tried to say. And that was the message, that you can use combination of metformin, SGLT2 and a GLP-1 receptor agonist and be able to induce significant weight loss. And you can get now below 6%, which is very achievable. And because these drugs, neither metformin, SGLT2, or GLP-1 will induce hypoglycemia, which will be the limiting factor. Yeah, I agree with that.
And Dr. Anshul, we should keep on trying our best. It's like when you have to explain to your patient may say, you can ask your patient, if you score maybe 33% in your school exams or 60%, are you happy with that? Or would you like to go for a distinction? Would you like to score 100%? So similarly,
Correct.
we should try to bring it as low as possible,
Correct.
as long as it is safe. The Japanese guidelines mention this very clearly. And the ACE, American Association of Clinical Endocrinology guidelines, also ask for an A1C less than 6.5, not 7. Another question on SGLT2 inhibitor biology. And this is about diastolic dysfunction, heart failure with preserved ejection fraction. Is there conclusive data now to show that SGLT2 inhibitors do benefit heart failure with the preserved ejection fraction?
Yes, they do. They do. Actually, now, initially the SGLT2 inhibitors were have benefit in HFrEF, reduce ejection fraction, but now empagliflozin preserve study show very clearly that they also improve heart failure. So now both reduce ejection fraction, preserve ejection fraction are both benefited with empagliflozin has been demonstrated. And there's coming up a study with the empagliflozin that probably is going to show exactly the same. So now the SGLT2 inhibitors can be used for both types of heart failure.
So like Dr. Anshul says, exercise is a proven therapy for heart failure with preserved ejection fraction, and so is empagliflozin now. We can use that. In India, there's another question. In India, we have both oral and injectable GLP-1RA. We have dulaglutide once weekly, liraglutide once daily, and we have oral semaglutide. How do we differentiate between these three in terms of placement in renal failure, in CKD, and also heart failure and ASCVD? Any difference between these three?
Well, first of all, you have the three options where the patient can choose. One, if they don't want an injectable, I think that oral semaglutide, as I show you, is very efficacious. That gives you an A1C reduction of 1.4, 1.5% in around 4 or 5 kilograms. Liraglutide gives you basically the same thing. Actually, we did a study where we compare oral semaglutide versus liraglutide, and they show non-inferiority in terms of A1C reduction. Actually, oral semaglutide had a little bit more weight loss than the daily liraglutide. If people have no problems with injectable, I would prefer the dulaglutide, which is once weekly, and also has shown to be very efficacious with an A1C reduction of around 1.5% in around 4 kilograms. In terms of kidney prevention, there is some suggestive evidence that GLP-1 receptors could be beneficial. Has not been shown so consistently as with the SGLT2 inhibitors. There is an ongoing study with semaglutide looking at the effect on kidney function. So there are some suggestions that they can help with the kidney, the progression of kidney failure. Oral semaglutide, we don't have any data there, but there are some suggestions that the semaglutide can do as well. And so probably oral semaglutide, but the one that is the choice between for kidney prevention, certainly SGLT2s have more stronger evidence. As for MACE, the GLP-1 have a stronger evidence. For heart failure, certainly the SGLT2s have more stronger evidence than GLP-1 receptor.
So for CKD, for prevention of CKD progression, we can choose SGLT2 inhibitors and GLP-1RA. The choice of GLP-1RA will depend upon the patient's preference. But if it is weight loss that you are gunning for, then oral semaglutide is certainly a better choice. Many more questions coming up, sir. And Dr. Shabana Anwar asks about gliptins and their side effects. There's also a question about sitagliptin and its dose. So sitagliptin dose actually will depend upon the EGFR. If the EGFR is normal, you give 100 milligram once a day. If it is below 60, then you give 50 milligram once a day. And if the EGFR is below 30, then you can give 25 milligram once a day.
Yeah, and that's exactly the reason why I prefer the linagliptin. I mean, we did the study with Carmelina. Dr. Sanjay, I think that we're having problems with your internet again. But in terms of renal function, the ideal in that respect as a DPP-4 is linagliptin, 5 milligrams, where you don't need to have any adjustments. You don't need to have any adjustments for the renal function. In people for sitagliptin and so on, you need to change the dosages. Is a bit of a problem because people don't monitor the eGFR as they should, and that's why linagliptin it would be a preferable DPP-4 if you want to use a DPP-4. We tested that in Carmelina, where we actually included patients with a significant kidney failure, and there were no issues with hypoglycemia, and even you still have a little bit of improvement of the A1C without increasing the risk of hypoglycemia. And the good thing is that once a day without needing to monitor or without needing to make any adjustments. In that respect, linagliptin is preferred than sitagliptin.
Right. We acknowledge the questions and comments. We acknowledge the questions and comments. We acknowledge the questions and comments coming in from all of you.
We have, okay.
There's an echo actually. We acknowledge the comments and questions coming in from all of you. Dr. Shrikant, we'll get back to you after the meeting and get you in touch with Dr. Vaishali Deshmukh, madam. Dr. Saurav Chaudhary, you speak about generalized weakness and diabetes. We call it diabetes fatigue syndrome. Please allow us to address this topic. It's like a PhD topic in itself, weakness and diabetes, asthenia and diabetes. Please allow us to address this on one of the subsequent Sundays when we do our FDC Diabetes Essential programs. So we meet you every Sunday night at 9 p.m. and we have a different topic related to diabetes. It's clinical, it's relevant, it's pragmatic, and we'll take up diabetes fatigue syndrome in one of the coming weeks. Dr. Vinay Desai asked about hypoglycemia at breakfast and how to give insulin. Dr. Vinay, if you allow this question also, we can address later. And maybe our back team, Rahul, can put up in the comment box the link to the previous programs that we've had in Diabetes Essentials, where we've discussed insulin therapy in detail. One question for you, Dr. Julio. This comes from one of our renowned pediatric endocrinologists. Her name is Dr. Mudita Dhingra. She is from Haryana. And she says, can I use oral semaglutide as first-line therapy in obese type 2 diabetes?
It hasn't been tested in a thing. Doesn't have that indication for that. There is a recent tested one of the GLP-1 receptor agonists. I can't remember which one is. I think it's exenatide. The weekly exenatide has recently reported a study in pediatric type 2 diabetes. But the oral semaglutide, it probably is going to work, but it hasn't been studied. It doesn't have an indication for that. Dr. Sanjay, are you still there?
Right. Dr. Julie, if you can hear us, there is a question from Dr. Upinder Kumar. Are you able to hear us, Dr. Julie?
Yes, sir, we can hear you, sir. You can continue with the question.
Yeah.
Okay. So this question from Dr. Upinder, a 33-year-old lady with a strong family history of diabetes mellitus, both parents. Her BMI is high. So 33 years, lady, obese, strong family history. Currently, her glucose levels are normal, fasting ranging between 90 and 120. So that is the pre-diabetes range. Postprandial is normal. HbA1c is 6, again pre-diabetic range. She wants to plan pregnancy. So what do we suggest to her? An obese pre-diabetic lady planning pregnancy.
I think that the weight loss is the most important factor there. And certainly, you now have an indication for a GLP-1 receptor agonist She's 33 and she's overweight, correct? She's overweight. Is she overweight?
Yes.
Hello? Okay. So I
Yes.
think that it will
BMI is
be,
high.
then I think that makes sense to give a GLP-1 receptor agonist, get it to lose weight, and then stop the GLP-1 receptor agonist and let her get pregnant. And then monitor the fasting plasma glucose very closely, and do some monitor the A1C, and do glucose monitoring, measure the fasting and measure the postprandial when she's pregnant. And if she's pregnant and develops diabetes, then she needs to be started on insulin, and some people will start it on metformin. The metformin may be another option to give to this lady, because metformin. But I will try to, despite the fact that metformin is used in pregnancy, and people with PCO, for instance, they get the metformin, they get pregnant. They use metformin in the first trimester, but I think that now you have the tools with a GLP-1 receptor agonist to get it to lose weight, and then let her come into the pregnancy with no medication, see what happens.
Yeah. So the best, actually, because you've got the patient in the preconception phase, the best is to get her to lose weight now. If she takes liraglutide or semaglutide or orlistat to lose weight, then she has to practice contraception as well, for at least 3 months. And if she
exactly right.
And if she happens to choose a bariatric surgery, if that is indicated, then she should avoid pregnancy for at least 1 year or 18 months after.
I will not recommend bariatric surgery. That would be too aggressive, especially since now you have
actually, yeah. And he has not mentioned the BMI also, so we really don't know how severe the obesity is.
No, I would not recommend the bariatric surgery. Very good, Dr. Sanjay. How many more questions you have?
We have so many questions. Allow me to take 1 or 2 important ones.
Okay.
We have thousands, sir, at least 50 more.
Oh, gosh.
Let me take the tough ones for you, and then I'll continue with all the other questions once you leave. So we'll take a few of the difficult ones, the important ones. C-peptide, do you do it in diabetes practice? Does it help in diagnosing the type of diabetes? Does it help in choosing the correct therapy? Serum C-peptide.
No, I hardly ever do a C-peptide. We do C-peptide in all the clinical trials to make sure that we have people with type 2 or type 1 diabetes and so on. I don't do that. I mean, I think that the phenotype is enough to do that. If you have somebody in the 30s, 40s, or 50s who is overweight, who has a mild or moderate hyperglycemia and is not ketotic, you know that that patient has type 2 diabetes. And if somebody is with the multiple oral agents and is obese and the A1C is elevated above 7%, I will start the insulin and so on if they are on all the medication. So I don't use routinely C-peptide. Never use a C-peptide to decide when to use basal insulin. I think that the clinical acumen and the clinical judgment is enough. If you have somebody on metformin, a DPP4, and an SGLT2, or metformin, an SGLT2, and GLP-1, and it's overweight, and the A1C is 7.8, and so on, and you want to get it below, and then they're on 2, 3, or 4 medications, and they're overweight and asymptomatic, but with chronic hyperglycemia, I don't need to do the C-peptide. I will start the basal insulin there.
I would agree with you, and I would also say that I very rarely prescribe C-peptide, and in India it's very frequent to see prescriptions for serum insulin to help and diagnose diabetes and to help and diagnose polycystic ovary syndrome. And I myself don't remember actually having prescribed a serum insulin for diabetes or PCOS ever.
No, I know.
Dr. Rosenstock, thank you for a wonderful presentation, and thank you for being so patient with our questions.
Thank you so much.
I understand that you're hard pressed for time. If you allow, perhaps we can request Mr. Basu to give a vote of thanks, and then I will continue with the other questions because we have lots pending.
Thank you so much, and I really enjoyed and appreciate Dr. Sanjay being this. I like it the way you moderated. That's the way a real chairman should do it, not just let the speaker, because we both are specialists. I really appreciate your comments. I learned from you. I learned from the questions. So I like very much your style of presentation. And then it was a real pleasure to do it with you. It was a real
We've
pleasure.
enjoyed having you
That's
with
the
us.
way a chairman should do it. Give
Thank you, sir.
your own input, because your
Thank
input
you.
is also valuable.
Thank you. Mr. Basu, please.
Thank you, sir. I think this was one of the sessions where we enjoyed thoroughly, and we enjoyed every second of being you here in our show. And we thank you for being up with us. And we make sure that maybe next time when you are coming to India, we will be again coming with an association with you. Sir. Thank you very much.
Yeah, I only have one request.
Yes, sir.
Can you send me that preparation that raised that woman? I need that energy drink that you have.
Sure, sir. Sure, sir. Sure, sir. That is Enerzal.
do.
That is FDC is a pioneer in India for oral rehydration solutions.
I'll get it. I mean, that was very impressive.
Thank you, sir.
Okay.
Thank you, sir. Thank you.
You'll really enjoy it. Yeah.
Bye-bye.
Thank you, sir.
Thank you.
Bye,
you.
sir.
Thank you. We'll continue with the questions. And can I request Rahul is with us backstage. Rahul, can you put up the questions in the chat box, please? But we'll
Sure, sir,
continue
sure.
with the question. There
Sure,
was
sir.
one question from Dr. Khalid about peace. That is why you will find obese people with diabetes. They will not have hypoglycemia because the receptors of insulin, they resist the metabolic effects of insulin. But the mitogenic effects you will see, you will find that patients become obese, they have darkening of skin, they have acanthosis nigricans, and they also develop skin tags. So all these are signs of mitogenic effect. The insulin receptors are responsive to the mitogenic effects, but not responsive to the metabolic effects of insulin. So that explains why PCOS patients do not get hypoglycemia. Dr. Vijay Kumar Pandey says pancreatic diabetes needs lifelong pancreatic enzyme support. Yes, that is correct. How much dose is needed? This varies a lot from patient to patient. So I can tell about my practice, Dr. Vijay. The pancreatic enzyme replacement I use most often is Creon. We have 10,000 and we have 25,000 units tablets. You can give 10 3 times a day. You can keep on changing also immediately before the meal, during the meal, after the meal. Swallowing or chewing. Each patient will have a different response. If 10,000 doesn't work, you can give 25,000. You can also give 35, 10 plus 25. And there will be some patients who will tell you that I take 1 tablet before the meal and 1 tablet during the meal. That also works in some patients. How do you test? Usually history is enough. Steatorrhea, weight gain, so avoidance of steatorrhea and bloating, and occurrence of weight gain. These will tell you that your pancreatic enzyme replacement is working. In my part of the country, in Haryana, pancreatic diabetes is present. Though we are perhaps the richest state of the country, we still see pancreatic diabetes in our poor socioeconomic status. So when will I suspect pancreatic diabetes? When a young male comes to me with long-standing history of diabetes, long-standing history of uncontrolled diabetes, evidence of malnutrition. You look at the patient and you realize he has protein energy malnutrition and also micronutrient malnutrition. Low BMI and absence of ketones. Then I will suspect pancreatic diabetes. How do I confirm the diagnosis? An X-ray or an ultrasound of the pancreas will suffice. Usually you will see a shrunken pancreas plus minus pancreatic calcification. Patient will also complain of abdominal pain and steatorrhea or malabsorption. And then the treatment is small frequent doses of insulin analogs along with, like Dr. Vijay has correctly pointed out, pancreatic enzyme replacement. Dr. S.K. Ghosh asks about erectile dysfunction. So first of all, if the patient is obese, try to reduce weight. You can use any drug, though there is one study which says that glimepiride increases serum testosterone levels. And usually the drug that I use in my practice for erectile dysfunction is tadalafil, 5 or 10 milligram at night, continuously for a few days. And then once the patient gets used to it, maybe 1 or 2 hours before the act. The second choice is sildenafil. There is a sildenafil subcutaneous, sublingual preparation also. And if the patient is in a hurry and the patient says, Doctor Sahab, I want something which I can take 15 or 20 minutes before the act, then sildenafil sublingual, 50 milligram is what we prescribe. So caffeine, Dr. GD says that yes, there are studies which show that caffeine increases beta cell size. There are other studies which show that caffeine causes osteoporosis. So I don't think we will be using caffeine as a drug for metabolic syndrome. But if you are a coffee drinker, you can continue taking coffee in moderation. Dr. Biswajit Haldar shares a case report of 70% blockage in one vessel. Do I need angioplasty? So now, yes, if it depends upon which vessel it is. If it is left anterior descending artery, then I think a stent would be required. But your symptoms, your ECG, and your angiography report or CT angio report should be concordant with each other. If your symptoms and ECG report and echo report are different from the CT angio, then even if you get an angioplasty done, the symptoms are not going to resolve. So maybe what your friend is telling you that your symptoms or your echo report are saying something else, the CT angio is saying something else, so don't worry and you continue with medical management. Dr. Shabana Anwarji asks about use of insulin in antenatal patients. So the drug of choice is Detemir. That is the one that is that has best proven safety for antenatal patients as a basal insulin. The second best is Glargine, and even NPH you can use, neutral protamine hagedon. So Glargine can be used in antenatal patients, but it is good if we prefer Detemir or NPH. For the fast acting, you can use human insulin or Aspart or Lispro. All are approved in pregnancy. In general, in pregnancy, it is a good idea to use analogs because they are much safer. There is a lower risk of hypoglycemia. Dr. Vijay Kumar also says, which one is better, empagliflozin or dapagliflozin in heart failure? There is no head-to-head trial of these drugs, but for heart failure with restricted ejection fraction, both have got good evidence. For heart failure with preserved ejection fraction, like Dr. Anshul Singhai had pointed out, empagliflozin has got good data. So as of now, empagliflozin is the only drug that you can use in preserved ejection fraction. Dr. Ruby Gulati shares a patient, a 50-year-old gentleman, obese, diabetes for 10 years, taking vildagliptin, glimepiride, and metformin. So 3 drugs. Fasting is still 140. PP is 190. We have to check the HbA1c. If the patient is doing well and HbA1c is 7, we can continue the same, Dr. Gulati. But however, if the HbA1c is not up to the mark, since the patient is obese, it would be a good idea to add an SGLT2 inhibitor, DAPA or EMPA or canagliflozin. Do note that even if HbA1c is normal, still we should add the SGLT2 inhibitor because that will give us cardiovascular benefit. So we are adding, of course, for glycemic benefit and also for CV benefit. So these are all the questions that we had. If there is any other question, we are still around and please put them up again. And if there's anything we have missed out, I apologize.
Questions, no more questions, sir.
A few questions, please allow us to inform. Maybe Rahul and Mr. Basu will talk to you about diabetes essentials. We have it every week. And they will tell you how to access the old videos because there we have discussed insulin in great detail. Diabetes fatigue syndrome is something important. Thank you for pointing it out. And maybe towards the end of this year, we will have a series of webinars on fatigue. One of the ways of correcting diabetes fatigue is actually Enerzal 0. But then there are different causes of fatigue. So if you have anemia, then Enerzal 0 won't work all that much. Then you have to give Vitcofol. That will help in correcting the fatigue. So we will certainly have a series of topics on diabetes fatigue syndrome towards the end of this year. But I'd like to thank you all for being with us today. So many questions, so much interaction. In English gives a very warm feeling. Allow me to speak in Punjabi. Thand pe gayi. So there's another funny thing. In English, it feels warm, and in Punjabi, thand pe gayi. It feels cold. It feels cool. So with this, I'd like to thank you all for being part of our journey towards Azadi Ka Amrit Sehatmand Mahotsav. Thank you.
I have a question for you because we have gone through the whole presentation of Julio Rosenstock and we always try to understand because today's presentation was quite a unique presentation and I don't find anything anyone suitable than you, because you are one of the top endocrinologists practicing in India, and you travel along, and you are also connected to the Western professors and all. So the question comes to you, it's like that when I feel that when Dr. Rosenstock's presentation is, I think 5 years ahead than what we are practicing, and what do you feel like? Or is it the same thing, the way India practice will be, maybe you see changing in next 5 years?
It is practically the same. All the message he gave was relevant, except maybe with regards to sulfonylurea use. We have an extensive history of using sulfonylureas in a safe and smart manner. So there, I think sulfonylureas will continue to remain our mainstay. We have been using them for a longer period of time. We are able to differentiate between the modern sulfonylureas, that is glimepiride and glycoside sustained release on one hand, and we are able to differentiate them from the older SUs. So that is one thing. Second thing is that in the Caucasian world, insulin resistance is a greater contributor to diabetes pathophysiology. In India, it is insulin resistance and secretory defect, both. So when Dr. Anshul Singhai says that if you have a secretory defect, why don't you correct that? He is right. So when insulin will be required, certainly it will be required. But until then, you can use sulfonylureas or DPP4 inhibitors. So that is one difference that we have. Another thing is it's about cost and accessibility. Now, as doctors, we are so accessible to our patients. Getting a glucose, showing a fasting postprandial is not a big deal in India. When you see Dr. Rosenstock saying that I don't advise postprandial glucose because that is too invasive, that is too much of a burden for the patient. But I don't mind giving a CGMS.
Yeah.
He is right in his context. He is not worried about the cost.
Correct.
But for us, we are all friendly neighborhood doctors. We are happy seeing our patients' glucose values every week, every day, whenever they want to show us.
Yeah.
And it is just 30 rupees for the glucose test. CGMS is 6,000 rupees. So I think in context, when we place it, what he's saying is exactly right. We all think the same thing.
Right. So with this, I think because we needed to have that interpretation, because I felt sincerely that it's probably 5 years ahead from what we are practicing today. So I thought this is a pertaining question which should be asked to you. So with this, sir, I thank Dr. Sanjay Kalra for always being with us, and will be always with us for next another maybe whole session of Diabetes Tea Essential with Dr. Sanjay Kalra. And we are happy to have you, sir, because it's good to have once in a while speaker from Western world, but everyday solutions will be always be taken by you, sir. With this, I think we thank you and all the audience being with us on late night Sunday, on the evening of Independence Day, and they are celebrating the 75th Azadi Ka Amrit Utsav. So I sincerely thank them and enjoy your day tomorrow. Jai Hind, sir.
Jai Hind.
Thank you, sir.